Dear jury, dear audience, welcome to the 3 months progress report. I'm Balázs Dorony and my PhD is about stabilizing options in total hip arthroplasty. So I am a PhD student and a resident at the Department of Orthopaedics at Semmelweis University. My supervisor is Dorony and my SMS is Alex. And my vision is to improve the life quality of people living with endoprosthesis through enhancing their range of motion and joint stability. And my mission to achieve that vision is to clarify the indications for different endoprosthesis designs through applying the available scientific data. So let me tell you about my 2 ongoing projects. My first project is the investigation of different hip prosthesis designs to avoid dislocation after revision hip arthroplasty. And my second project is about the investigation of patients who underwent revision hip arthroplasty in a Hungarian surgical center. Let me tell you about my first project. So what is an arthroplasty? To put it simply, it's a surgical procedure to replace a joint with an artificial joint. The 2 most common types of an arthroplasty is the hip replacement and the knee replacement. Below on the X-rays you can see examples of different hip replacement designs. So some people call the hip replacement the operation of the century, but why? Well, because the lifetime prevalence of osteoarthritis is around 10 to 15%, and is the main indication for hip replacement. And that's why orthopedic surgeons perform around 1 million or more than 1 million hip replacements every year worldwide. And it's a huge number. That's why the annual cost burden of hip replacement in the United States is around $15 billion US, and it's growing every year. And when a complication arises after a primary hip replacement, a revision surgery will become necessary, and the revision surgery is even more expensive than the primary surgery. Well, the most common causes of a hip replacement revision is the aseptic loosening, the periprosthetic fracture, and the dislocation. And actually, at a normal center, 20% of all endoprosthesis surgeries are revision surgeries, but according to some projections, this number will double by 2026. As these surgeries are complex and radical, we would like to avoid their complications as much as possible. Here on the X-rays you can see examples of situations where something went wrong after a hip replacement. From left to right, you can see a dislocation, a periprosthetic fracture, and an aseptic loosening. And on the bottom, on the X-rays, you can see the end results of different revision surgeries. Here you can see that these surgeries are radical and huge, so to say. Well, our biggest concern after performing a revision hip arthroplasty is the chance of a dislocation. But what can we do? Let me tell you about some options we have to prevent that. Well, one of the options is using a dual mobility design. Here you can see an example of a dual mobility acetabular cup. It has 2 points of articulation, an external and an internal. It has increased range of motion, and it is designed to prevent dislocations. And it is used in primary and revision surgeries as well. Another option is using a constrained liner. Here you can see an example of that on the picture. It is designed originally for recurrent instability, and it is holding the femoral head captive within the socket. That's why it is preventing the dislocation. It usually uses a locking ring to do that. Here you can see that on the picture. Here is the locking ring. And it can be used in primary and revision cases as well. And another option would be to use a large femoral head. We call it a large femoral head when the diameter of the femoral head is 36 millimeters or more. It offers a greater impingement-free range of motion, and it increases the jump distance required for dislocation, and it offers more stability, although it will result in more component wear and a higher risk of liner fracture. And our aim of our research is to find out which prosthesis design is the best option to use in a revision hip arthroplasty to prevent dislocations. So our clinical question regarding our research is that does a dual mobility design or a constrained liner or a large femoral head decrease the dislocation rate compared to standard acetabular cup in revision hip arthroplasties. And our population will be people who underwent revision hip arthroplasties, and our interventions are the mentioned dual mobility design, the constrained liner, and the large femoral head design. And our control will be the standard acetabular cup used in normal hip arthroplasties. And our outcomes of interest are the dislocation rate, the aseptic loosening, and the overall implant survival. And our hypothesis is that these designs are superior to the standard acetabular cup regarding dislocation rate in revision hip arthroplasties. And the clinical implication of our research is the decrease in the dislocation rates after revision hip arthroplasties, and that's why it will potentially lower the hospital costs as well. Well, we performed our systematic search using the mentioned search key. Here you can see our results. We have quite a few, actually. And here you can see the flowchart of our selection process. Let me tell you some information about my second project. We are planning to start our project in January. And the project will be about the investigation of patients in a Hungarian surgical center. To be more precise, the orthopedic department of Semmelweis University, because it's one of the biggest revision centers in Hungary. And they have extensive clinical experience in hip revision arthroplasties. And they have a diverse patient pool because it's a national institute. So our aim is to analyze the data of patients who underwent revision hip arthroplasty in the orthopedic department of Semmelweis University. The data collection will be done by one PhD student and two student researchers in an Excel sheet, and the data will be validated by a doctor, and we don't have ethical approval. And we are involving right now only one center because we contacted only the orthopedic department of Semmelweis University. So to summarize my two ongoing projects, we will be investigating different hip prosthesis designs in hip revision surgeries. And we will be investigating patients who underwent hip revision surgery in a Hungarian surgical center. And the planned completion dates are January and June of 2023, respectively. And let me close my presentation with the words of Sterling Moss. To achieve anything in this game, you must be prepared to dabble in the boundaries of disaster. Thank you for your attention.
Thank you for the presentation. I have a question about the different types of prosthetics that you can choose. What are the pitfalls or those regarding to the aging? For example, I can imagine that the one which consists of two parts, the surfaces of moving is much bigger, and maybe it ages faster. So how many years can be used? Are they the same or it's different?
Thank you for your question. Well, actually, these are quite new designs, so we don't have much information about their long-term survival right now. That's why we are investigating that. But usually, the rule is the more constrained the prosthesis is, the increased the component wear is. So it will lessen the life of the components. Constrained basically means it's more stable, more stabilized. So as I mentioned, maybe I can go back to the slide, but for example, with the large femoral head, the polyethylene liner between the cup and the femoral head is slim, so it will increase the possibility of liner break. Yeah, just to give an example.
Thank you. How would you define the aseptic loosening and with which tool would you use for confirming it?
Well, aseptic loosening, it happens when we experience loosening on our radiological pictures, for example, X-rays or CTs, and without the proof of a septic situation.
Hi, very nice presentation. Thank you so much. I just have a question. I'm really curious. I saw in your first project you have 4 full articles, but you have 3 investigations. Do these 4 articles compare all 3, or I don't know if you understand my question?
Yeah, thank you for your question. Actually, you got me, because on the slide I mentioned that the full text selection is about 60% done, so we are expecting more full articles to be included in our study. But the 4 that is already included, they usually investigate all of the mentioned prosthesis designs.
Oh, and just another question. Is this going to be like a network meta-analysis, or will you compare them separately?
Well, we were discussing that, and we came to the conclusion that if it's possible, it will be a network meta-analysis, but I didn't want to mention that because we don't know yet, because of the full text selection process is where it is right now.
Thank you so much.
Thank you.
Thank you for your presentation. I would like to ask about the second project. So what are the main outcomes or main focuses of the registry, what you are planning to build?
Thank you for your question. Well, the main outcomes would be the same outcomes as we are investigating in the meta-analysis, and the data of the patients, for example, BMI, age, sex, so the general data of the patients as well. These would be the main outcomes we'll be investigating. Yeah.
Thank you for the presentation. I have only a quick note. So since you are planning to establish a registry in your second project, instead of the Excel sheet, I would propose to use an open source clinical data management system. There are plenty, and then it's much easier to continue with your data acquisition. For instance, Open Clinical, but there are hundreds, and that can be pretty useful for you, I guess. If you need advice, I can assist you with the data acquisition.
Thank you for the suggestion.